Hola, bienvenidos y bienvenidas a todos y a todas en esta tercera y última jornada dentro del ciclo de conferencias en línea, innovación y tecnología en la respuesta humanitaria. Soy Camille Nussbaum, soy investigador en el Instituto de Estudios sobre Conflictos y Acción Humanitaria, un centro basado aquí en Madrid, el IECA. Es un gran privilegio de participar en esta tercera mesa, en esta tercera conferencia en línea. Y como sabéis, en los dos primeros encuentros hemos abordado cómo la tecnología es un factor clave en la respuesta humanitaria y también hemos explorado cómo las alianzas con el sector privado pues, pueden suponer una fuerza para promover la colaboración, para mejorar los proyectos y programas humanitarios. Hoy nos vamos a centrar en otra cuestión que conecta con todo esto, que es cómo la tecnología está gestionada y percibida en un entorno de trabajo para los humanitarios, que es el trabajo con los refugiados y las refugiadas. Vamos a tratar específicamente las consideraciones éticas, ver cómo el desarrollo, el uso de la tecnología se plantea de acuerdo a las cuestiones éticas. Evidentemente, lo que nos interesa es ver cómo la tecnología supone una gran oportunidad para producir grandes cambios, un gran impacto. El lema de este ciclo, como sabéis, es Big Chance, Big Change. Ahora vamos a empezar con una sesión de apertura. Let's start with the opening session and we'll connect with Rotterdam with you, Stuart Campo. You are the team lead for the data responsibility of the United Nations Office for the Coordination of Human Action, UNHCR, and you supervise the effort to advance the safe, ethical, and efficient management of data. Yeah. Sure. Loud and clear.
I somewhat bizarrely can't hear you, so I will just assume that everything is okay, and apologies in advance if I repeat anything that was said in the introduction. My name is Stuart Campo, and I work for the UN Office for the Coordination of Humanitarian Affairs in the Center for Humanitarian Data, where I lead our data responsibility workstream. I'm really grateful to join this event today and appreciate the invitation from Caixa and UNHCR to be part of this discussion. My job in delivering opening remarks is hopefully to clarify a bit what we're talking about when we refer to ethical aspects of technological innovation in humanitarian settings. As we are all likely aware, there's been a massive rise in the use of technology and data in humanitarian response over the past 10 years. And in just the past few years, we've seen more attention on the ethical aspects of this type of work. It's important to be really clear what we're talking about when we refer to innovation and ethics and where the two do or do not meet in order to have a productive conversation. So in the next few minutes, I'll try to offer some clarity on those terms and then really look forward to the panel discussion where you'll hear from a number of experts about this topic in more detail. In terms of innovation, of course, there are many definitions in the sector, but I like to think of it as something new or different that adds value. Think of it as creative problem solving, ways to approach complex issues in new and different ways. Specifically today, we're looking at technological innovation, but that is not limited to digital technologies, as you will see. Most of my remarks are informed by our experience at the Center for Humanitarian Data in promoting more responsible data management, but hopefully they can be more generally useful to you all. So once we've established that innovation is really about solving problems, the first salvo to keep in mind is that you should not be working on a solution if you don't have a problem driving that solution development. One of the most common trends in the sector, particularly around technological innovations, has been a range of solutions in search of a problem. So if you're thinking about starting an innovation project or bringing an innovative solution into your humanitarian efforts, the first question should always be, what problem does this help us solve? And a better question to start from is, what problems are we trying to solve and how might we go about doing that in new and different ways? That should really always be the starting point for innovations. Once you've decided that it is appropriate to proceed in exploring different innovative technologies, that's where things get much more complicated. And that's really where the discussion of ethics of innovation comes in. When we think about ethics, broadly understood, we're talking about basically right and wrong, a common sense of what is morally right and wrong, but also in a context like the humanitarian sector, a common sense of what is professionally right and wrong based on a common set of norms and principles. In the humanitarian space, ethics is very much based on principles, the core humanitarian principles, first and foremost, but also the various additional professional standards and principles that have evolved in the sector over the years. So if you're trying to develop an innovation or an innovative approach based on the humanitarian ethical framework, it's really about asking yourself a set of questions around what ethical issues might arise in delivering that project and how you can go about mitigating them. A simpler way, perhaps, to understand it is basically a balancing of benefits and risks. What do you expect this innovation to deliver in terms of benefits for affected populations and your organization more broadly? And what are the potential risks that we can expect to encounter, and how can we mitigate those so that we make sure that we're doing no harm while hopefully delivering better assistance for the people that need it the most? Some of the common ethical dilemmas that I imagine we'll hear from our speakers about today relate to the additional hazards or harms that technology can introduce or amplify, the knowledge of outcomes from projects which, by definition, if something is new and different, we may not have a great deal of certainty on. So having to make decisions in the face of uncertainty is a common theme in discussions of innovation ethics. The distribution of risks and benefits, so who benefits and who faces risks or who bears risks. This is a critical one, and for me, maybe the most important question. We should never be asking what are the benefits and what are the risks of a project. We should be asking who benefits from this project and who bears the risk. Finally, to what extent can we make sure that innovation in the sector is participatory and that we're not actually exacerbating power imbalances or inequities by introducing new and different tools that only certain parts of a population may have access to? Now, if we try to think about navigating these dilemmas, there are many different frameworks for how you can go about doing this. And I would like to just offer a kind of high-level set of recommendations based on our experience at the Center for Humanitarian Data, and then give you, hopefully, a little bit of food for thought. Broadly speaking, ethics needs to be built into the processes that you as an organization have in place for developing projects more broadly. So the first step really is establishing a clear code against which different decisions will be made. Again, in the humanitarian sector, this should be grounded in the humanitarian principles, but each organization, based on their mandate, the nature of the work that they do, and other contextual factors, will need to define for themselves what their clear ethical code of conduct for this type of work looks like. Once you have that in place, maybe the most important area to invest is actually making sure that you have processes, tools, and capacity to deliberate ethical dilemmas. The very nature of a dilemma is that there is no obvious answer. So we need to empower humanitarian staff throughout the stages of an innovation project to identify, grapple with, and ultimately resolve the ethical dilemmas that they face. This is really critical and is a recognized gap in the sector in terms of both our expertise and our capacity to grapple with ethical issues emerging from new technologies or different ways of working. Finally, something that can help with this more deliberative process and investment in deliberation on ethics is introducing something we refer to as ethical audits. This is a concept that we've borrowed from one of our collaborators looking at specifically algorithmic auditing. And Kathy O'Neill is her name. She talks very specifically about how these ethical audits can help you basically understand against a standard the degree to which a project does not present ethical risks and the degree to which those risks were reduced while the benefits were maximized. I realize that was already a lot, and you're about to hear some really exciting examples of projects. So maybe just to recap and leave you on hopefully a clear understanding of how ethical aspects of technological innovation continue to evolve. First, if you're starting an innovation project, make sure that there's a clear problem you're trying to solve and not the other way around. Don't peddle a solution in search of a problem. Start with a problem and then explore what solutions might be available. Next, establish a clear code of conduct for ethical practice in the innovation space and more broadly. This should be rooted in the humanitarian principles and should be something that all staff are aware of and capable with engaging with. Support staff by building their capacity and introducing clear procedures for how ethics fits into decision-making and how ethical dilemmas can be debated and resolved. Finally, consider ethical audits as a standard practice. That's something that you can both learn from while in the course of a project and look back in a kind of after action style to understand what went well, what could have done better, and what you can learn from a project to improve in the future. I really look forward to the rest of the discussion and hope that these brief remarks can help people think more clearly about the ethical aspects of technological innovation in the humanitarian sector. Thank you.
Thank you so much, Stuart, for this opening session. Hopefully you can hear me now, and sorry for the technical problems we had. It seems now it's fixed, so sorry for that. Your presentation was actually really insightful. Thanks for that. Thanks for clarifying the key concepts, the big questions around ethics and technology innovation. I'm sure now we'll explore further these questions with the next panelists along the different case studies we'll have today. Thanks. Después de esta presentación inicial, vamos a empezar ahora con las presentaciones de los diferentes panelistas de este evento en línea. En esta última jornada nos vamos a centrar, como hemos dicho, en los aspectos éticos. Queremos destacar, viendo esa relación entre tecnología e innovación en el contexto humanitario, queremos destacar que evidentemente la tecnología no es nada si no miramos el factor humano. La tecnología siempre va con un propósito, como nos decía Stuart, y tenemos que analizar ese factor humano y todas las consecuencias éticas que están alrededor de esto para que el uso sea correcto y adecuado. Sobre todo cuando hablamos de contextos muy complicados, por definición la acción humanitaria se da en conflictos armados, en contextos de desplazamientos o en contextos de desastres naturales. Entonces, en estos contextos muy complicados, las cuestiones éticas pues, son muy importantes. En esta sesión de hoy nos vamos a centrar entonces en esos aspectos éticos de la innovación tecnológica aplicada a la respuesta humanitaria. Antes de empezar, algunas preguntas sobre el formato de la sesión. Si ya habéis participado en las dos sesiones anteriores, las dos últimas semanas, ya sabréis un poco cómo funciona. Vamos a invitar ahora a varios panelistas que se van a conectar desde distintos lugares en el mundo para compartir algunos casos de estudio muy interesantes. Después de estos, tendremos un debate entre los panelistas para profundizar algunas cuestiones y al final queremos abrir la discusión con vosotros y vosotras que estáis ahí viéndonos, escuchándonos a través de la plataforma, y es por eso que existe un módulo de preguntas dentro de la plataforma a través del cual podéis enviar vuestros comentarios, vuestras preguntas, especificando, si lo veis oportuno, a qué panelista queréis preguntar ese asunto. Entonces, no dudéis a lo largo de las presentaciones a tomar notas y a enviarnos vuestras preguntas. Como decíamos, al final hemos reservado un tiempo para que esto sea participativo y que podamos escuchar vuestras preguntas y comentarlas. También sabéis que a través de la plataforma tenemos un módulo one-to-one que permite, si lo deseáis, os podéis quedar conectados y conectadas después del evento y podéis entrar en contacto con los panelistas, incluso hablar con ellos para profundizar algunas de las cuestiones de interés. Entonces, no dudéis en utilizar esta herramienta si queréis aprovechar esta oportunidad. También comentar, esto es un evento que queremos compartir a través de las redes sociales. Si vais a comentar a través de Twitter, Facebook o LinkedIn, otras redes, pues estamos utilizando con todo el equipo esa palabra clave, hashtag #MomBigChange. Mom es el nombre, como sabéis, de este proyecto que nos interesa hoy. Y esta es la palabra clave si queréis rastrear o participar en estas discusiones en redes sociales.
Get involved in the conversation online, use hashtag #MomBigChange. And let's start now with different presentations.
Now I would like to share their experience in complex humanitarian emergencies, more specifically in the non-invasive diagnosis of anemia, and a passionate case study located in Ethiopia. In Atlanta, we have Eva Leidman, a nutrition epidemiologist at the Centers for Disease Control and Prevention of the US government and Johns Hopkins University. And today, alongside with her, we have at the field
Ella en el campo tenemos a Dorothy Gazarwa en Etiopía, que es nutricionista para ACNUR Etiopía. Bienvenidas a ambas, es un placer teneros hoy aquí. Hola, Eva.
Hello, pleasure.
Hola, un placer.
Over to you.
Tenéis la palabra.
Okay,
Gracias.
thank you. I'm Dorothy. I'll be starting
Yo soy
the
Dorothy y voy a
presentation.
empezar la
Thank
presentación.
you all for this
Y gracias
opportunity
por
to
darnos esta
present to you the
oportunidad para
ethical considerations and
presentaros las
opportunities
consideraciones
in
éticas
evaluating
y
use of the non-invasive technology for hemoglobin measurement in humanitarian settings. With Eva Leidman, as she has already been introduced, who will present the technology while I present the background of the anemia problem in Ethiopia. Next. So basically, globally in UNHCR refugee camps, we have 3 out of every 5 refugee camps having a prevalence of anemia that is above 40%. This denotes a severe public health problem, which has been denoted as, which is above 40% and therefore denoted as a problem of severe public health significance. The problems of anemia are caused by multiple issues such as nutrient deficiencies, one which is iron deficiency anemia, folate, vitamin A, vitamin C, and vitamin B12 deficiencies. We also have infection and hookworm infestations. We have hereditary diseases such as thalassemia and disease, and also chronic blood loss resulting in anemia. Next. As you can see in this UN has a comprehensive approach to ensure long-term nutrition well-being of refugees, which includes anemia. Look at acute malnutrition. We look stunting, which is also known as chronic malnutrition. And in this graph, you'll see the highlighted countries in yellow have operations where standardized expandation surveys were conducted in 2018 that include anemia, not only measures for malnutrition and stunting, but also anemia. Next. In 2008, the UNHCR Strategic Plan for Anemia Prevention, Control, and Reduction was launched. 4 major were made. The first one was post the existing activities, which were malaria control and strengthening the iron folate supplementation for antenatal care. This is looking at pregnant women. There were also new activities that were introduced, one of which is provision of fortified foods, which were lipid-based, and also nutrient powders to try and address this challenge. In different sectors to ensure that anemia is addressed. And lastly, it was to increase the ability and measure the outcomes and results of all the efforts that were being put in. Here in the graph, you will see that in all have been made. This assessment, only 3 out of 68 assessed camps in 2018 were actually within the WHO standards, which is below 20%. So the anemia prevalence was actually below 20%, which is acceptable, in only 3 out of 68 camps. But if you come with global acute malnutrition and you compare also with chronic malnutrition, you can see that clearly anemia is lagging behind in being addressed in the refugee camps. Next. So this presents the current situation in the study area, which is Gambela, southwestern Ethiopia, where refugees are coming in from South Sudan. We have about a population of 300,000 refugees compared to a population of 39,000 host community or Ethiopians, so predominantly refugees. And as you can see, the trend, we have 7 camps. You'll see up to Okugo. These are 7 camps where refugees reside. And the studies that have been conducted a period of 3 years, you can see that the prevalence of anemia has been consistently high, with the most recent results showing that all camps are above 40%, which is the critical threshold, with only the Ngwenyel camp, that is 1 camp out of 7, that is below 40%. So all the other camps, mitigation measures in place are doing. We have iron folate supplementation, we have malaria control, we have provision of fortified foods, and also Caixa has the opportunity of Caixa has presented us with ability to provide fresh food vouchers in some of the camps. So for us to be able to address this problem, we need to be able to consistently and routinely identify, treat, and monitor the impact that we are having. And currently, the methods that we're using are invasive, and would like to look into the non-invasive technology that would ease population-wide assessment of our population. I will now hand over to Eva Leidman to take us through the technology. Thank you.
Next slide. Thank you, Dorothy. So as mentioned, I'll now speak about the study we have planned in Gambella and ethical considerations. But first, let me start with discussing current barriers to measurement of hemoglobin in humanitarian settings. Or, as nicely framed by Stuart in the introduction, let me start by laying out the problem we're trying to solve. The HemoQ device is the most widely used field method. It was developed in the 1990s and is today routinely used in refugee settings. However, the HemoQ requires specific microcuvettes and controls that are not available locally in most countries with refugee camps, resulting in frequent stockouts or unavailability of these supplies. In addition, the device requires a capillary blood sample. While not as invasive as a venous sample, the capillary samples are frequently refused by children and caregivers. As a consequence, while hemoglobin is measured annually in the surveys mentioned, very few humanitarian settings include hemoglobin measurement in outpatient clinical settings or as part of nutrition programs. Additionally, screening is generally limited to the most vulnerable groups, children 6 to 59 months. Screening in other groups, like school-age children, are quite uncommon. Next slide. The table here presents hemoglobin conducted using different devices. On the left is the HemoQ device that was mentioned previously that's routinely used in humanitarian settings currently. On the right is the novel device being considered in refugee settings, the RAD67 or pulse co-oximeter. As can be seen, the devices are similar in terms of performance characteristics and costs, but are based on different principal methods. The co-oximeter measures total hemoglobin using multi-wavelength photophotometric technology. In other words, it measures the difference in absorption of visible and infrared light to characterize the amount of oxygenated blood, oxyhemoglobin, and deoxygenated blood, deoxyhemoglobin, in arterial blood. The device uses a simple probe placed on the fingertip. The most common co-oximeters have been developed by the Masimo Corporation. While approved and in use in the US and the EU, pulse co-oximeters have not been widely used outside of studies in low-income settings. Next. The study being proposed in Ethiopia will include 2 phases. The first phase aims to evaluate device accuracy, whereas the second phase aims to evaluate device precision, or repeatability of measurement. In the first phase, hemoglobin will be measured in a random sample of children presenting to outpatient care facilities. In this phase, the 2 point-of-care devices, the HemaQ and the RAD67, will be compared to a lab gold standard. This comparison will allow for measurement of accuracy. In the second phase, hemoglobin will be measured in a population representative sample of both children and pregnant women. In the second phase, 2 measurements will be taken with each of the point-of-care devices. By comparing the first and second measurement for the same device on the same child, we can evaluate precision of the 2 point-of-care devices. Next slide. In designing any research, one must consider medical ethics. This is of acute importance in contexts in which settings involve persons that are acutely vulnerable. Here, children, and particularly refugee children. While all principles are relevant, there are 2 that I'll focus on today, as they were the focus of our research team in designing the study. They include autonomy and human rights. Autonomy relates to individuals' ability to make informed decisions about personal matters and freedoms. This principle is more commonly discussed in the context of conditions that cause compromised autonomy, such as dementia, but does here have acute relevance in settings where UNHCR is both an investigator in the research, as well as responsible for the safety and well-being of the population, providing not only their shelter, but also their safety, their food, and other resources. As such, ensuring the population can truly give informed consent, fully understanding the research, and feeling empowered to refuse participation is paramount. The second principle is one of human rights and justice. Particularly relevant when conducting research among vulnerable populations is the concept of ensuring they bear a fair burden of the benefits of the research, the burdens of the research, and a fair share of the benefits. Research should not be performed in refugee settings only because of logistic feasibility. We must ensure that potential direct benefits exist. We felt confident in the context of this research for 2 reasons. 1, there has been significant evidence regarding the efficacy in other populations. As such, the interest of our study was generalizability of these findings to the refugees, given their unique risks. Second, there was a clear plan in place to ensure the refugees fit should efficacy of the technology be demonstrated. Next slide. To that first point, a large number of studies have been completed evaluating the accuracy of the pulse co-oximeter technology. The presented slide shows the results from a 2019 meta-analysis comparing the accuracy of the RAD7, panel A on the top, and the Pronto 7, panel B on the bottom, older versions of the device we're testing. While a large number of studies have been conducted, very few have included children. Those few are indicated with red boxes. And we know of only 1 study that evaluated performance among children in a low-income setting. This study was conducted in a tertiary hospital in Rwanda. In this context, we felt that the science supported the safety and potential benefits of the technology, but that further research was needed to justify and establish efficacy in the context of our settings with different populations and different challenges. Next slide. Similar ethical concerns informed our thinking about future potential rollout in the camps globally, depending on the results of the proposed study. In particular, as discussed in the introduction, we considered and balanced benefits against potential harms. In terms of benefits, the device could potentially be used in 3 ways, or a combination of the following. First, it could be used to improve coverage and quality of existing programs for populations currently covered. For example, it can help in programs routinely measure hemoglobin in outpatient visits and prenatals. This is recommended globally, but as mentioned, rarely practiced. Second, the device could be used to expand activities for these same target groups. As noted, the HemaQ is not amenable to large population screenings, whereas the non-invasive technology could be used to do house-to-house screenings, as is commonly done for acute malnutrition. or it could be integrated into programs like food distributions. Blanket screenings could serve to identify children earlier with more mild forms of anemia. Third, the device could be used to expand coverage to new targets like school-aged children. However, such benefits must be considered in light of potential harms. These harms are poorly characterized currently and are failing the study. We may find the device has slightly lower sensitivity, meaning they're likely to miss a child who is anemic, or lower specificity, likely to falsely identify a child without anemia. The purpose of the research is to characterize these features so that they can accurately be considered in evaluating future rollout. We are also interested in evaluating the performance of the device, such as how it performs in hot or humid temperatures. There's additional costs associated with using the device, as these too are things we'd like to consider in a risk-benefit. Next slide. Thank you for your time and for support for this work. We're happy to field any questions. Thank you.
Thanks, Dorothy. Thanks, Eva. It was fantastic. Actually, the technology worked. It was a really great privilege to have these two views on this problem, on these solutions from the at field level, and with the most scientific, with the scientific perspective with you, Eva. So thanks to both, and I'm sure we'll analyze more and more these questions in the debate. Siguiente ponente.
Next speaker, based in Madrid, Laura Medialdea. She is a researcher in Action Against Hunger, and she's also part of the research team from the University of Madrid. With Laura, we're going to see a case study, which is an app to be used in mobile devices. It's the some Photodiagnosis app, which allows to identify acute or SAM with using the image taken by, or the picture taken by a mobile phone. So I want to thank Laura for being here today with us. So she'll be talking about her experience in Guatemala. Hello, good afternoon. Thank you for inviting me to this session. I believe it's extremely interesting, and I have loved everything you say. The presentation and the opening session has been great, so thank you. Well, I would like to explain this project, and besides that, we'll mention some of the ethical aspects that we have found along the way, and I believe they are very important. It's important to know those ethical aspects when you start designing a research project and carry it out. So we're going to start by showing this project. What's SAM Photodiagnosis? Well, this project, as you say, involves an app which allows us in real time, because you don't need the use of internet, to have a classification of the nutrition of a child under 5. Taking a picture of the left arm in this case. And it's fast, it's reliable, and it's easy to use. So anybody without having anthropometric knowledge, which is how acute malnutrition is nobody diagnosed, well, anybody can have access to this knowledge. We'd like to tell you now what the project is about, so when we start talking about the ethical aspects, you can better understand these challenges we had to face. Well, the research was carried out in Spain. It started in Spain, and we continued with it in Senegal. And we started with it because this project, well, what's behind this project, it's a technique used geometric morphology, which means measuring the changes in shape with the use of geometry. Well, this technique had never been used with live human beings. It had been used in bone studies, but it had never been used with living human beings, and we had to use the whole, or create the whole technology. So we chose the Spanish population to start, because it was at hand. And after using or designing the whole methodology, we went to Senegal to implement it. In this context, we compared children suffering severe acute malnutrition and children who were would not suffer from any kind of malnutrition. Well, what's the technique about? As you can see in this picture, there's a picture of a girl here. She has a series of dots on her body. I don't know if you could see them, but those are the red spots you can see on screen right now. So the first thing we have to do is to identify those areas that are always going to be repeated in a children's body. We have to do that with image software management tools, and they have to be identified. After that, according to these dots, we have to find the green dots around the body you can see now on screen. Once we have calculated all these dots, all these points, next we have to digitalize all these points using coordinates. So X and Y coordinate digitizing, so we have a representation of the shape we want to study. And in the following step, we will be able to have a model to understand the shape of the human body. Well, this methodology that's already been published is used to research in Senegal with children, some who were suffering from malnutrition and some children who did not suffer from any malnutrition. We have also been able to see that this technology has allowed us to classify which kind of malnutrition, and the left arm is the region of the body that shows the best results. So that's why this left arm is the part of the body that we have used to generate or create our SAM photo app. And it was a challenge, because as I mentioned, everything, all of these things were very new and nothing like or nothing similar had been created. So I'm going to show you how SAM photo works. Well, the first thing we have to do, just like in any other power, we have to log in. Once you've logged in and you want a new case, well, we have a questionnaire and we'll be able to classify information, because given the we have to protect data, because we cannot mention the name of the child we're going to take a picture from. Next step, take the picture of the child we want to study. They have to be placed on that kind of a green template. Once the arm is there, we click next and we get the result, because all the algorithms are included in the app. Here, I said that probability is 75%, but what you normally see is a color code. So you've got red, orange, and green. So to know if they are suffering kid is suffering malnutrition or not. Well, this is SAM photo. That's how the SAM photo app works. Something that we have to bear in mind is that the application is linked to the indicators that are currently used to diagnose severe malnutrition. As I mentioned earlier, we're talking about anthropometric data, so we're using the MOAC and WHC. So we believe that our tool is going to be extremely interesting and useful, because these measurements, if taken in a health center, well, that's great. But if we have to take them, we have to do this on the field, we haven't got the right personnel, the right resources to do it. However, this app will allow us to identify these children suffering malnutrition, send them to the healthcare, where they will be taking the measures and they will have access to treatment. So the positive aspect of this app is that a kid that's been identified as suffering from malnutrition, when they get to the health center, they will be identified as suffering malnutrition using MUAC, so the mid-upper arm circumference, or or by any other methodology used in the health center. Well, where are we at right now? We have developed the app and we are validating it in Senegal. We hope it's going to be validated by 2021, or mid-2021, sorry. One of the aspects we're validating is a technical aspect, so we want to make sure that that's working, and when a child is identified as suffering from malnutrition, we want to make sure they are actually suffering it according to WHO metrics. And we also want to include all the different groups that the WHO is including. We also try to make sure that the app's working at a technological level. And last step is a user experience, because developing a tool that's great is useless unless users don't want to use it, or unless our users want to use it, sorry. So that's what we're checking as well. If we need to have in different languages, which are the colors that users prefer. Those things seem less important, but the truth is that they are very important, and developers give these things a lot of importance. Once we're done with this phase, our next objective is to escalate the project. And to do so, at a technical level, we want to test the app at least in 6 different human populations to take a look at the variability in the diagnosis, so how the shape of those populations changes and if that has an impact on the diagnosis. We will also be including chronic malnutrition research, and we are starting with this project in Guatemala, which is the country with the highest number of people suffering from malnutrition. At a technological level, we want to develop a tool within the mobile app that will allow the person that's using the app following the different cases. So this kid was diagnosed with malnutrition, how is he doing? And those things are extremely interesting to be able to follow their daily activities. We also want to create a consolidated database. So in the near future, we'll be able to create platforms to integrate these up in national health systems. And the last level, which is customer experience, we want to keep on developing it as well to be able to escalate the project. Well, once we've seen what the project's about, we're going to take a look at ethical considerations. I divided it into 2 parts. First, the intrinsic ethical aspects, and also the external ethical aspects. So I'd like to mention some of them, which are the ones that we've had to be concerned about in this project especially, but there are many others. When you carry out a research project, you have to describe a protocol, scientific protocol, that's going to be presented in front of an ethical committee. In our case, we sent it to a Spanish committee, and also to a committee in Senegal. And you have to explain what you're going to be doing, how you're going to do it, and solve some ethical issues that are already asked in this protocol. You shouldn't start working in any countries without this approval, because first of all, everyone should know that you are carrying out this research, especially for the scientific community, for the local scientific community. It's very important to know what you're doing. I guess nobody would like to know that suddenly you had scientists from a different country to carry out a project and there's nobody else involved. There's nobody from the country involved. That's also a reason why it's very important to involve local academia, so local universities, in our project. Next step, after getting this approval, is to inform the participants correctly. And in our case, participants were children. And what we had to do was to inform the tutors, so the legal guardians. So what we did was inform through the community leaders, well, the community references for, well, in Spain were the teachers, where we carried out the research. And in Senegal, if we were going to schools, teachers, well, the person to talk to, and if we going straight to different communities, we had to talk to the health workers in that community. So what's important is that we should empower these people so they can explain to the population what we want to do, so the population is able to ask questions as well. Because in many cases, you might feel afraid to ask as a foreigner about things, or people from all your community, but you are not afraid of asking someone who's part of your community. Of course, we're available, so they can ask us questions if they wanted. Well, next step, once you have informed the participants, and in this case the guardians, we need them to sign the consent to participate in the research, but also explaining what we're going to be doing with the data we're going to be gathering from the participants, who's going to see it, who's going to keep them, and we inform them the fact that they can actually modify all the data they have given us. Once we've done that, we have to let them know that participation is voluntary. So in this case, it's not that participation is voluntary. I mean, I'm talking about the guardians. So guardians might be fine with the kids participating in the research, but kids might not. When kids are over 6, we ask them to nod if they agree. However, if you're 8 months old, I mean, you cannot ask them to nod their head. So the only thing we can do is to observe them. If we see they're complaining, or if they don't like it, or anything like that, we cannot insist. Even if the guardians of the kid want to continue, we have to respect the will of participants. So in our case, there was something that we had to take into account, and it was very important, because you cannot ask a baby if they want to participate in a certain research. Next step in our research, as I mentioned, we had to guarantee confidentiality and anonymity of data of participants. In that sense, I wanted to highlight the difference between both concepts. Confidentiality means that I am not going to tell anybody what I'm doing. So that means that the data I'm gathering are going to be kept in this way. I'm going to do with them what I'm telling you I'm going to be doing with, and I will let you know who I am sharing that information with. Anonymity means that through the data I'm going to be gathering, nobody will be able to identify you. Well, this was very important for us because we were working with children. In the first research we carried out, we were gathering pictures of the whole body, and sometimes you could have some, bits and pieces of the face, or that information sensitive. What we always said is, well, this is the picture you take with the app, and we always make sure that the face is not there, and if possible, we want to show the fingers. So although the resolution of a mobile phone camera is not that good, we want to make sure they cannot get the fingerprints, because that is a piece of information that allows you to identify someone. Next, given that our objective with the use of those images is to be able to capture these dots, which will be allowing us to make the classification, well, the information we keep in the project is the one you have on the right side of the screen, the shape of the arms. Because, and as you can see, the morphology here is different. Pictures are erased from the mobile phone the moment these points are generated, because the truth is that the image is only useful for us to extract this image. So this is a very important ethical aspect that we always have to let users from the app know. which is that the user of the app is not going to have access to those images, and images are not going to be sent in the internet. What we are sending to a service are those coordinates with those dots that will never allow you to identify a person. The last aspect I have to take into account is the feedback that we were giving the participants, because in a research project we very rarely, or participants very rarely have or benefit from it. So you have to try to find a way to benefit the participant. In our case, we decided we were going to provide them with a nutritional report to the families of the kids who have participated in our research. We explain in it. We explain how they were identified, how we identified the status of the kid, if they were fine. Okay, if they were suffering from malnutrition, they were referred to the national health programs. If they were fine, we also told the family, "You're doing great. Just keep on doing this." These aspects might not seem very important, but they actually are, because at the end of the day, you work with people and for the people. So we must never forget that's people we're dealing with. And this is part of the respect you should also show to the people you're working with. If you are thinking about extrinsic consideration, that's the name I gave to them, because they are not. Those are not the considerations you have to take into account when developing your research project. But they do happen. Nobody tells you when you speak to the experts, or those are things that are there. And those are aspects that we should always take into account. First of all, the social and cultural aspects. When you carry out some research, you might have been able to develop your research protocol, and everything's very well defined, everything's fine, everything's great, and suddenly you get there and you find out that the person who's going to participate in your research does not want to participate, or you tell them, "Okay, let's take the kids' clothes off," and they tell you, taking their clothes off? Why should I do that? To weigh them? So those are things that, they're obvious to you. You have to get the clothes off when children are weighed, because that way you reduce the error. But maybe culturally that's not like that. Maybe an issue we had was that they didn't want men to be in the room when children were not wearing any clothes, which was basically the whole process. Well, that was something we had not anticipated, because it did not happen in Spain, but it happened in Senegal. Something that did not happen in Senegal, but it did happen in Spain, was that as soon as a kid starts crying, children told us that the child was crying and they did not want to participate. However, in Senegal, if the child was started crying, well, it makes sense, because normal children don't like you to be touching around. Children started laughing. They, I'm here in front of you. I see there's nothing going on. They're just angry, and they were right. 2 minutes after that, they were normally fine. So those are. You've got these social and cultural aspects that have to be taken into account, because they might cause psychological damage. If we force someone to take their clothes off because that's a protocol, well, that might be bad for that person. Or if we force a kid, even if the kids are, even if they, if a child is crying, even if the parents are in front of them, but if we're seeing that they're suffering, we have to make sure that we are taking care of children. Something else we saw was how data is treated by third parties. Maybe we want to gather this information to create this tool to be able to diagnose using the mobile phone, and that's our objective. But maybe our partners or our counterparts might have other objectives. This is an example that hasn't actually happened in this project, but it has happened in other contexts. And this is a piece of research, and we were carrying out a survey to know the nutrition of different people and be able to give some advice on how they should be feeding themselves. Well, they had suppliers who were giving them materials to measure body characteristics. They have other associations and other partners. And what they found was that when sharing this data, some of the counterparts opened food businesses near the areas in which the survey was carried out. Some of the counterparts created online apps to sell food and healthy and fitness apps. And another counterpart, what they did was, they launched a research which involved food preference according to sexual orientation, which is, it's been widely spread, and this is how a normal piece of research can cause harm to those participating into the event, because in this case, some people lost their jobs because the sexual preferences were shared. So we must highlight that we have to be very careful when dealing with data, and that's why it's very important to draft that document I was mentioning before. You need to know which is the traceability of the data that we're taking, who's taking that data, where are they going to be, who's monitoring that they're safe, and many other things. Another aspect that we have to bear in mind are the donor interests. In principle, all the donors have cultural objectives or sustainable objectives, and just doing something good for their community. However, we should always take into account the fine print, because when things are linked to data, well, sometimes the use they want to make of that data is just something that we don't know. It does not feed our objectives. So we all have a chart. We all and humanitarian organizations have a charter that we make sure that all the people who work with us meet them. We just make sure they meet our criteria. So that's a way of selecting or the people we should be working with and who we shouldn't be working with. But in our case, for example, some of these technological companies that had all the information about cloud information and cloud services, well, they would sponsor us as long as we kept our data in the cloud. And the fine print, we saw that they were going to sell their information to third parties because we were using their service. Well, that's a conflict of interest. Last aspect, the national and public interests. In many cases, we say, well, my research is great. It's going to be great for this population, and I see it's going to be a revolution, and actually the population needs it. We find out that the government tells us no, that they don't want it, or that it's a challenge for them, or risk for them. That's why I chose this center, because I believe it shows what we should try to understand when carrying out a research project. Let's see if I can get that phrase on screen. Here you go. The fact that something's necessary or is proper does not mean that we can do whatever we want. We should always respect the context you're working in, and we should know that no matter how beneficial we believe our actions are, we cannot force anybody and do anything we want, and we cannot do whatever we want especially in the context we're walking in. It's not the same thing to be walking in a context like Spain and walking in an area where there's a conflict. So you must realize some aspects, and sometimes from the research perspective, we couldn't have imagined before starting. In that sense, when we work with national policies, research has a very positive aspect, which is that organizations try to improve the policies that countries have, and in many cases those countries are doubtful because there's no evidence for it. But in this case, the research carried out at a humanitarian organization level generates evidence that allows us to use a very important tool, which is advocacy. So we have seen that as we generate evidence, we are stronger to be able to carry out this support or try to lobby to change the legislation in some countries. So not everything's negative. Well, last, I would like to mention that all of these aspects, or these extrinsic aspects I mentioned, might cause a conflict of interest. But good news is that we as individuals, we don't have to make the decision, because today there are many different policies that you can see some of the examples here. We have many codes of ethics that have been implemented already. Can you check? Click. Okay. Well, there are many guidelines that we can check. It's not that we can't check, it's that we should check them when creating our research protocols and get to know where we want to implement that research and the aspects on which we want to implement them. So it's not our decision, really. And I'm showing a balance next to it, because it's not, saying when you find a conflict of interest with a supplier or with a donor or the expert panel we've got, it's not a matter of weighing things and checking how am I going to have a better result. No, the only thing you have to do is check the ethical legislation. And last, I just wanted to show you a bit of dialogue that's normally thought to be said by Groucho Marx, and on what's a person willing to do for a certain amount of money. In this case, a person for $1 million, they're willing to do many things, but for $1, not so much. So, well, what they're saying, in the dialogue is clear, is that we have already negotiated what we're going to be doing. Now we're only negotiating the price. That's it. That's all I want to share with you. Thank you, Laura. It was, your presentation was great and very easy to follow. Thank you for all the detail. I hope we will be able to elaborate a bit more on it in the round table and in the one-to-one sessions as well. Having said that, we're going to start with the last presentation. Before that, I only wanted to share with you and remind you that you can ask your questions to the different speakers through the Q&A module in the platform. I also want to remind you that we're using the same. I want you to remember that we're using hashtag Big Change if you want to get involved in the conversations we're having in the different social networks. And as I was saying, we're now going to Switzerland to for the last presentation with Albert Picado. He's a researcher in tropical disease research, and he's worked to develop tools to treat tropical diseases around the world. Today he's going to be talking a rapid test for sleeping sickness in a case study developed in Uganda. Hello, Albert.
Hello, everyone. I'll do the presentation. So thank you very much for the presentation. Thank you for the organizers for inviting me to be part of this webinar. So I'll be briefly talking about the sleeping sickness, and in particular, or using sleeping sickness as an example on how important is access to diagnostics and
¿Cómo podemos acceder a los
neglected tropical diseases and among refugees, and using an example and a study that we conducted in Uganda. So briefly, just a couple of slides about FINE. That's where I work here in Geneva. Next, please. FINE is a foundation that based in Geneva, as I was saying, that we basically work on the development and implementation of diagnostic tools for disease diseases linked to poverty. I'll encourage you to go and check out our website if you want to know a little bit what we are doing. Next slide, please. We are basically working on a number of programs or a number of diseases, which include antimicrobial resistance, malaria and fever, hepatitis, or tuberculosis. Today, I will be talking about one of the programs. This program. Next one. For those that do not know, the NTDs or neglected tropical diseases is a large group of diseases. There are actually 20 diseases, which are very diverse, but they all share a couple of common features. One is that they are linked to poverty. They affect the poorest and the most marginalized communities, but as well they are linked to stigma, social exclusion, and disability. As I was saying, there are 20 of those identified by WHO. Some of them, many of you will know, like rabies, leprosy, but others, or dengue, but others are really not well known by the general public, like echinococcosis, for example. Today, I'll be presenting, or we'll be talking about human African trypanosomiasis that some of you may know better as sleeping sickness. Next, please. Yeah, next. So, sleeping sickness, or as again, human African trypanosomiasis is, without getting into much detail, but is a parasitic disease transmitted by a vector, by a tsetse fly, and caused by Trypanosoma brucei-gambiense or rhodesiense parasites. It's endemic in sub-Saharan Africa, and patients that suffer that disease have basically two stages of the disease, can have two stages. The second one actually has neurological symptoms, and that's what gives that name of sleeping sickness to the disease that is sometimes is better known with that common name. Next, please. Interestingly, there's a very interesting relationship between sleeping sickness and conflict in particular, but as well, it's fascinating how sleeping sickness is linked to development in sub-Saharan Africa, and as well how development is linked to sleeping sickness transmission in different areas and different time points. And in particular, the relationship between sleeping sickness and conflict has been well documented. I have just put here a couple of papers where actually this is reviewed, and I say it's interesting to see the social link between this disease and in particular with conflict. Next, please. One of the challenges we have with sleeping sickness is actually diagnostics. Diagnosing patients is actually challenging, and here I'm just showing a diagram illustrating a little bit the current algorithm to diagnose patients, and I'll just go through it briefly. On the left side, you have the first phase or the first stage, which actually requires a screening, actually using serological tests looking for antibodies, in patients that either have symptoms, which are usually non-specific to the disease, or live in a high-risk area. People that are positive, so they have antibodies against the trypanosomes, they need to go to a second stage, which is actually confirmation. confirmation is done by actually visualizing the parasites in the body, in different in blood, for example. Finally, those that are positive, so that they have parasites, they still need to go to the third stage, which is actually what we call staging, which is actually you need to conduct a lumbar puncture, which is obviously not easy to do or not pleasant to determine if the patient is in phase 1 or stage 2 of the disease, as this actually informs the treatment that needs to be used. So next, please. So the as I say, diagnosing sleeping sickness is complex, and for several years, the first step, which was this screening, this serological test, was done with a test called CAT, which is an agglutination test. And here in that slide, I'm just showing the machine that is actually now used or is used to do this test. And this machine has actually played an important role in the control of the disease, but it has some disadvantages, and mainly the main ones are that it requires cold chain and storage for storage, and it also requires electricity. The impact of this is actually then this diagnostic tool could only be used in facilities, in health facilities where there was electricity. And what you have on the right side of the slide is a map of North Uganda. This area is the area that is endemic for sleeping sickness in Uganda. And what I'm showing in that map is actually the 4 centers, health centers where CAT, so serological testing, could be done in Uganda. These are the 4 red dots that you see. This is the situation, or this was the situation in 2013. So only those 4 sites actually people had to go there to be tested for sleeping sickness. Next one. What happened in 2013 is FINE and other partners got together and developed a rapid diagnostic test, which was at that time the first rapid diagnostic test for sleeping sickness. Obviously now, and thanks to COVID, everybody knows what a rapid test is. So basically, it's again a serological test that allows, it's similar or equivalent to CAT, but has some advantages. The first one is it allows a rapid diagnostic first, but as well, more importantly, it doesn't require electricity, cold chain, and it can be performed in basic health centers. And the change or the impact is somehow illustrated in the map, in the new map on the right side. And now we do not, what it illustrates now is with the small green dots that you may see, is actually all the health centers where now the screening could happen because RDTs were deployed in those centers. Next one. The result of increasing and implementing RDTs, so diagnostic capacity in a larger number of facilities, had an impact on access to diagnostics. And this is illustrated quickly in this graph. On the top graph, what you have is the distance or the percentage of people that the distance that people had to travel to get into a CAT center. So in 2013, and for example, you can see that in the region, and you can see the black line. So around 50% of the people had to walk more than 20 kilometers to get to a CAT center, so to get diagnosed for sleeping sickness. When the RDTs were introduced, and this is illustrated below in the graph below, actually all the population, 100% of the population in the endemic districts were within 6 to 8 kilometers from a center that will have an RDT, so that would actually be able to diagnose or screen for sleeping sickness. So that's obviously an improvement in access. Next one, please. So what is this technology? What is the relationship with refugees and potential use in a refugee crisis? As I was showing earlier, the region where sleeping sickness is endemic in Uganda is the north of Uganda, which is bordering South Sudan. As you know, South Sudan has been in conflict, I would say, short after it gained independence in 2011. And here I'm just showing a very brief outline of some of the events that happened from 2011 to 2017. Next, please. So again, a number of conflicts took place and have been taking place since then. And next, please. And this has resulted in basically a number of refugee crises. I would not only one, but actually a number of people fleeing South Sudan from 2014, but especially in 2016 and even more in 2017. Next, please. These refugees went to different countries, even internally displaced people, but as well, but a lot of them settled down in North Uganda. Here again, I'm just showing a map of, in that case, the triangles are not the health centers, but actually the refugee camps in North Uganda. So South Sudanese refugees that settled down in Uganda. And these were not small numbers. Next, please. There were actually very large numbers of refugees that settled down in a very short period of time. On the right side, you can see the graph showing the number of refugees and from South Sudan. And actually, one of the camps, one of the settlements in Uganda, Bidi settlement, was at that time the largest settlement in the world, refugee settlement. Next, please. And just to reiterate, these people were settling down in a sleeping sickness endemic region. And here what I'm showing is just a map produced by WHO showing the areas at risk of sleeping sickness, and these are represented mainly by these red colors. And if you go to the right side, you have a map showing South Sudan and Uganda, and actually, next please, where the refugees were settling down is actually in that region that is now shown, which, as you can see, is of high risk of sleeping sickness. Next, please. So what happened, what allowed, this new RDT that was, I say, developed and used from 2013, actually how this technology was used and how it helped it. Basically, it allowed to maintain the diagnostic capacity, even if more than 1 million people settled down in that region in very few months. And how we managed to do that is basically working obviously with the Ministry of Health in Uganda, but as well with NGOs working in the refugee camps, and by providing them access to these RDTs and training when required. And so in a way, expanding the network of facilities that were using the RDTs. And this allowed to identify cases among refugees, so to ensure that they had access to that diagnosis. And here, what you have on the left side is a map showing 2 of the cases in 2017 that actually were refugees diagnosed in Uganda, but actually were from South Sudan. Next, please. The RDTs also allowed to keep some level of diagnostic capacity or screening capacity in South Sudan, in the border area, which is also a high risk area. So this was sometimes discontinued due to the conflict, but somehow it allowed to keep that diagnostic capacity. Next. So a couple of just conclusions or remarks. One is, in that case, the RDTs allowed to maintain this access to diagnostics, which again, here we are talking about 2 vulnerable populations, if you want, one within another one, which is refugees and people that are suffering from an entity, which is a neglected tropical disease, which again, it's usually linked to poverty and marginalized population. So again, maintaining access to diagnostics is something that it needs to be ensured. And that's for sleeping sickness. And more in general, if we talk about entities and the complexity of these diseases, developing new tools and new diagnostic tools should allow improving access to care to these communities that by definition are marginalized. And these include refugees, which tend to suffer from this disease more than other communities. Next. So that's it, and I'm looking forward to discuss more about this case and the others. Thank you very much.
Muchas gracias, Albert, y bueno, gracias nuevamente a todos los ponentes hasta ahora. Aquí empezaríamos lo que es la mesa redonda. Nos queda no tanto tiempo.
We haven't got that much time. We've got about 10 minutes left.
Con lo que doy nuevamente la bienvenida a
So I would like to welcome Eva Leidman from the CDC in the United States and the Johns Hopkins University, Dorothy as well. That's connecting from Ethiopia. She is a UNHCR nutritionist. Laura Medialdea works in Action Against Hunger and participates in the research team from Madrid. And Picado, who works in the Center for the Development of new remedies for tropical diseases. So with the time we've got, I would like to ask you a question. Well, since this conference started, we have always said that ethical aspects are very important to identify risks. How are those risks identified, and how do you tackle those risks? That's what I wanted to ask to you first. Laura, you mentioned some guidelines or some codes that might let you clarify some of these risks. We have also seen some examples about the dialogue you have with technological providers like big data providers or cloud providers or the companies who want to test some sort of technical device. So, what's the conversation you have with those actors, and what's the dialogue you have with local authorities about those risks and those ethical considerations? So, how that's done in the real world? And of course, that's a question I wanted to ask you as well, but what's the dialogue with the populations we work with? So what's the communication we can have with the population we work with to share with them ethical aspects? So of course the topic's huge, but given that we have seen different cases, if each of you could please share some specific example around those dialogues you can have with different aspects to be able to communicate those risks. In some of the presentations, we've talked about consent, which is essential. And when working with the different populations, how do you do that? Or what is it that you consider having consent to do? There's a bit of a long question, but we can start with you, Albert, if you don't mind. So any idea, any thought about this dialogue with different actors? If you can share your experience with us. Yes, I'll try to keep it as short as I can, but I'm going back to neglected diseases. And when working with refugees, and that's what we saw in Uganda, priorities are normally different. Even with diseases, some of them are much more acute and more relevant. And a dialogue you have to start with the institutions, for example, that work in refugee camps to explain the relevance of a neglected disease. Well, this dialogue is complex and it's tough, and it has to be done, has to start the moment you get there, and you have to involve the refugee population as well. So it is one of the main elements, and it's not always obvious in the case of neglected diseases, because in many cases it's not part of the list of priorities, especially of the agencies who carry out activities in the territories we normally work with. Well, thank you, Albert. Stuart?
Would you like to answer this question? Maybe to share some examples?
Sure. Maybe just one example from our work with the Center for Humanitarian Data relates specifically to how we assess risks and benefits in the context of data management. So broadly looking at different types of assessments that organizations, including UNHCR, conduct as standard practice. These we refer to as data impact assessments, but they might include data protection impact assessments, human rights impact assessments, various forms of looking at the potential risks and harms, as well as the benefits of different projects involving data management. You could expand that concept pretty simply to innovation writ large. And we really encourage different organizations and actors to do this type of assessment. If I may, one other thought that's really important in the innovation context is the notion of experimentation and making sure that we acknowledge that most innovation work is inherently experimental and therefore should be subject to additional protocols and procedures that most academic institutions and medical ethics approaches would have as standard practice. It was really great to hear the panelists refer to these coming into each of their projects, and it's likely because they each relate in one way or another to health programming. But this should really be key. It's often something that's overlooked because innovation might be treated as non-research structured activity and therefore going around those kind of standard or traditional practices, but it's absolutely essential. So put in place these methods, use sort of consistent templates, tools, and terminology to assess risks and benefits, and then bring mitigation measures as well as optimization measures for the benefits into the design and management of your innovation project. Thanks.
Thanks, Stuart. Laura, ¿nos podrías compartir
Laura,
algún ejemplo tal vez sobre este
an example about this dialogue we have with different actors? Yes, of course. In our case, what we do is to get, well, whenever we start working in a certain context, we did that in Spain and Senegal and now in Guatemala, we create a multidisciplinary group, and we involve local members of the academia and politicians and the Ministry of Health as well, and suppliers, in our case technological suppliers, and we create different meetings and we start saying if there's something new, we talk about it, but we are always debating about different aspects, mainly ethical, about how we are going to start the project. But we have dealt, for example, the first aspect we worked on was consent, and how are they gathering. That way I can answer to the second question. Well, how are you going to be gathering consent within the rural context in Senegal, a place in which people don't know how to read or write in French? Who had explained the whole project in the language they use, and the consent had been translated to their language as well, but they didn't know how to read or write. So they're just going to, make a cross on that piece of paper. But the fact that, in case there's audit, that's enough. But that's different to making sure that people know exactly what the research is about and the fact they want to collaborate. So we ask them the questions directly. So whether or not they have had all the information, if they wanted to participate, we ask the questions in their own language. And that way, they could answer. That's one of the processes you carry out in this kind of context. However, one of the things that were part of that first debate, one of the suppliers told us, why won't we record a video of these people saying, yes, I give you my consent? And we asked, what do you want the video for? So in many cases, trying to solve an ethical issue, you find yourself in a different one. So we create those panels in which we all share concerns linked to the project, and we all, try to answer to those questions. And the truth, it's been extremely practical, because you get, the view from all the people involved, including the community, which is also part of that debate group.
Perfecto, Laura.
Great, Laura. Thank you for these examples. I also wanted to ask you, Dorothy and Eva, same question. Would like to share an example of this dialogue you have with the different actors, different companies, or the population in general? In your case, Dorothy.
So basically, in the settings, most assessments and even projects, before we start, we make sure that we meet, first of all, with the health actors, if it's a health program, and explain what exactly it is that we are proposing. And then along with them, we go to the community leaders. This is extremely important because they understand the context and they're able to feed into whatever innovation or whatever assessment. This, we start there by explaining what we are planning to do, why we like to do it, what the benefits are to them, and what the potential risks are, and how we plan to mitigate them. Then they feed into this right from the beginning before we actually start. And with this, we also, when we have concerned parties, such as women, or if it's targeting women and not men, then we have to meet with both parties, that is the men and that is the women, to understand how this could potentially impact even the actions within the community. And then we are able to reprogram whatever we are planning around that. So consent, right from the leadership to even the religious leaders, if it could likely have impact or they could support in relating this information to the communities, is always sought at the beginning for them to understand, and that mission to move into the communities if it is a research to collect that data. And then at the community level, when we are collecting information on a research or an innovation, even at that point, before we collect any information from them, why we are there, why we are collecting the information that we would like to collect, and the potential benefits and the risks and how we are mitigating them, and we show them what we are doing. Then we ask whether they are okay with us collecting information or not. If they are not, then we thank on to the next person. If they are okay with us collecting that information, we thank them, then we ask them to, then we make sure that they are comfortable in a comfortable setting, and then we start interacting. So that is what we do on the issue of consent. Thank you very much.
Thanks, Dorothy. And maybe Eva from your side.
Sure, just to add briefly. Can you hear me okay? Just to say, thank you, Dorothy, that was a nice explanation. And those processes in the camp complement some of the formal processes of going through ethical review. Our study will be approved by the ethical review body within the Ministry of Health in Ethiopia, as well as external organizations, Johns Hopkins and CDC. And the nice part about going through a formal ethical review is that there are systems in place whereby one has to lay out really clearly the costs, benefits, and risks of the study. And just to illustrate that point, one of the things we've been discussing recently that I'm sure other panelists have also been discussing is how this work is adapted in the time of COVID. Of course, the global pandemic presents new risks, that were not initially discussed at the time of designing this study, but need to be taken into account as they present risks, both for the benefit of the research participants as well as the study investigators in moving forward with this work. So going back to the ethical review bodies, as well as the local population, the local ministries, but also the local population, the refugees themselves, and reevaluating risk and benefits in order to decide what would move forward and what would not, has been a key illustration of this kind of ethical considerations.
Great, thanks Eva, and thanks to all of you. Gracias a todos y a todas por participar en esta mesa.
Participating
La
in this
última
panel, the last session we had in this cycle of webinars. I want to thank you, Stuart, Eva, Dorothy, Laura, and Albert. It's been a privilege to have you here and being able to open a debate around this very important aspects, and also taking a look at the very specific cases, and we know what's a risk when we talk about technology and innovation in humanitarian response, which is always complex, and its ethical aspects. I believe we have met the objectives of the meeting, so I wanted to... We're a bit late already. We are not going to have enough time to answer some of the questions asked to the website, but as I mentioned, we've got this one-to-one module that can be used through the website, and after this module, right after the end of the webinar, you'll be able to ask those questions live to the speakers and even talk to them. It's not exactly the same thing, but I would like to encourage all of you who have been sending questions to stay connected and ask those questions using this one-to-one module. I wanted to thank UNHCR and La Caixa Foundation for this great cycle and offering us the opportunity to reflect upon these topics, technological innovation in humanitarian response through this project, which is MUM, that we have gotten to know better in these presentations. I want to thank all the professionals as well, all the people involved in these 3 cycles, and well, speakers of course, but also all the technical support we got, all these people who are not seen on screen, but I make sure that this works as best as possible in the context we are living in. And having said that, I want to encourage you to start using this module, this one-to-one module. As you know, you've got 1.5 hours, so till 6:30 Central European Time. And you can get in touch now with the different speakers in the session. So this is a goodbye, but we hope this cycle, big change, has been useful and interesting. I hope the small seeds we try to plant, we hope they're useful in your future activities. This is a small contribution, given the huge challenges we're living, but I hope we will have all the chances to keep on adding our small contribution. Thank you, everybody. Thank you all. And well, take care and be safe, and we'll be seeing you right now on the platform using the one-to-one module. Thank you. See you soon.